Hello everyone, welcome back to the series of lectures in cardiology. Today we will be looking at a very important topic, which is your approach to bradyarrhythmias on the ECG. Okay, so let us begin. What is your bradycardia? So what is bradycardia? We know that the normal heart rate is 60 to 100 beats per minute. So if the heart rate is less than 60 beats per minute, if the heart rate is less than 60 beats per minute, we call it bradycardia. Okay. So what are the levels at which you can have a bradycardia? So you know already what is the conduction system of the heart, right? So this is your SA node, this is your SA node. The SA node is basically your pacemaker. So any abnormality with the SA node can cause a bradycardia, right? Then the impulses basically go to your AV node, right? So your impulses go to your AV node. So if your AV node also has an abnormality, you can also have a bradyarrhythmia. Then the impulses go through the bundle of His and they go into the right and left bundle branches. Okay. So if there is an abnormality in the SA node as well as the AV node, then where do the impulses start originating from? The impulses start originating from below the AV node, and this is what we call as your junctional bradycardia. Okay, this is your junctional bradycardia. Then there can be a block at the level of your bundle branches. If there is an abnormality at the level of your bundle branches, you can have your left bundle branch or your right bundle branch block. You can have your left or right bundle branch blocks. Okay. So these are the levels at which your bradyarrhythmias can occur. Okay. Fine. Now let us look at the first one. The first one is your abnormalities with your SA node. Abnormalities with your sinoatrial node. This is the one which is your pacemaker. So due to multiple etiologies, you can have something called as your sick sinus syndrome. Your sick sinus syndrome. So this is a sick sinus syndrome because any disturbance in your SA node can result in a sick sinus syndrome. So this can be due to intrinsic causes as well as extrinsic causes. So the intrinsic causes can be because of an ischemia. So SA node is supplied by which artery? It is supplied by the right coronary artery. So any RVMI or proximal RCA occlusion can result in a sick sinus syndrome. Okay, it can be due to infiltrative diseases like sarcoidosis or amyloidosis. Okay, it can be due to degenerative conditions such as Lev's disease. Fine. Extrinsic causes which can cause SA nodal dysfunction include hypoxia, hypothermia, raised intracranial pressure, hyperkalemia. The drugs which can cause SA nodal disturbance include lithium, tricyclic antidepressants and digoxin. Okay. So all of this, rather any of this can cause sinus node or SA node dysfunction. Okay. So what are the type of arrhythmias that you can have? So the first one is your sinus bradycardia. So what is the meaning of sinus? Meaning of sinus is that each P wave is followed by a QRS complex. So each P wave is followed by a QRS complex and the P waves are upright in lead 2. So this is what you mean by a sinus. So sinus bradycardia means that each P wave is followed by a QRS complex, but the heart rate is less than 60 beats per minute. Okay. So what are the causes for sinus bradycardia? So normally during sleep you can have bradycardia. An athlete's heart is usually having a bradycardia. Drugs include beta blockers, calcium channel blockers. What is this relative bradycardia? We have learnt in the chapter of pulse that relative bradycardia means that in fever, for every 1 degree Fahrenheit rise in temperature, the heart rate increases by 10 beats per minute. But the heart rate increases by 10 beats per minute. But in certain conditions, this does not happen, and this is what we call as your relative bradycardia. So, what are the causes for relative bradycardia? You see it in typhoid fever, you see it in brucella, you can see it in some cases of dengue fever, legionella, and you can see it in drug-induced fevers. Okay. Then the other cause for bradycardia includes metabolic causes like hypothyroidism, right. So, this is the meaning of sinus bradycardia. Okay. So, sinus bradycardia is each P wave is followed by a QRS complex, but there is bradycardia. Fine. Now, what is the second type of ECG? The second is your sinoatrial exit block. Sinoatrial exit block means that the SA node is dysfunctional. Okay. So, can you see in this ECG that you have a P wave QRS complex T wave PQT, and suddenly there is no complex at all. The next QRS P should have come here, but it is not there. That means what? Suddenly the sinus node has not functioned and the impulse itself is not generated. There is no P wave QRS complex at all formed. So, impulse itself is not generated, and this is what we call as a sinoatrial exit block. Okay. Now, if you see the distance between the preceding and the post QRS complex of the lost beat, right. So, this is the beat where it is missing, right. So, if you see the distance between the QRS complex before it and after it, it is equal to the QRS complex that straddles a normal complex. It is equal to the distance between the QRS complexes that straddle the normal QRS complex. So, this is denoted by B and this is denoted by A, and A is equal to B in a sinoatrial exit block. Okay. So, I hope this is clear. So, the QRS complex, the distance between this and this QRS complex, here you have a missed beat, is equal to the distance between the QRS complexes which are before and after a normal beat. Okay. Let us look at what is a sinus pause. What is a sinus pause? Here, similarly, you have a normal beat, and the next normal beat should have come somewhere here. But it is missing. Why? Because the SA node did not generate it in the first place. And this is followed by a huge pause. There is no electrical activity at all. It's followed by a huge pause. And this distance as you can see, the QRS complex between the QRS complexes that are before and after the expected beat and pause is much more than the distance between the complexes of the normal beat. So, B is much greater than A in a sinus pause or sinus arrest. So, what is arrested here? Here the sinoatrial node, the SA node is completely gone into arrest and there is a big pause. Okay. So, what happens here is that what is the major problem with this pause? The major problem with this pause is that there is no electrical activity conducted at all. So, at this point there can be dangerous hypotension or arrest, right. Dangerous hypotension or arrest depending upon the length of the pause. So, otherwise the patient can feel dizziness, patient can feel fatigued. Okay, fine. So, that is about your difference between your sinoatrial exit block and your sinus arrest. You have understood that? Now, let us look at the fourth one. This is also I would say a sinus pause, right. There is a sinus pause or sinus arrest, and suddenly you are seeing that there are complexes which are coming, and these complexes are different from the normal complexes. They are different from the normal QRS. Why do you say so? Because you can see here, this is your sinus beat. This is not having a P wave at all. If it is not having a P wave means what? Where do you think the complex is arising? It is arising from below the atria, because if it was arising from the atrium or a normal sinus, then you should have had a P wave. This is not having a P wave. So this is what we call as escape beats. This is what we call as escape beats, and they are produced from the junction, from the AV junction. So this is what we call as escape beats. So we have finished the diseases of the sinus node. So we have learned what is sinus bradycardia, we have learned sinoatrial exit block and sinus arrest, and what are escape beats. Fine. So this basically we have finished the disease of the first level. Now let us look at the bradyarrhythmias that arise from the AV node. We look at the bradyarrhythmias that arise from the AV node. Okay. So if there is a block in the level of the AV node, if there is a block in the level of the AV node, which part of the ECG will be affected? Naturally, it is the PR interval, because the P wave will be normal, because the SA node is fine. SA node gives the impulse to the AV node after the activation of the atria. So the PR interval will be affected, and this is what we call as your AV block. So let us look at the types of AV blocks. So the first type is your first degree AV block. The first type is your first degree AV block. In your first degree AV block, what happens is that this is your SA node. The SA node gives your impulse to the AV node. Fine. The AV node is conducting, but the conduction has slowed down. So each P wave is followed by a QRS complex, but there is a delay at the level of AV node. So the PR interval is prolonged. The PR interval is prolonged. So what is the normal PR interval? It is 0.12 to 0.2 seconds, right? So it's 0.12 to 0.2 seconds, 3 to 5 small boxes, right? So what happens here? It is more than that. So this results in a bradycardia, and this is your first degree AV block. Now let us look at the next one, your second degree AV block. Second degree AV block can be classified as type 1 and type 2. It can be classified as type 1 and type 2. Type 1 second degree AV block is called your Wenckebach phenomenon. It's called your Wenckebach phenomenon. So in type 1 second degree AV block, what are you seeing here? The PR interval here is, let us say, of x, then it becomes 2x, then it becomes maybe 3x. So I will not say in multiples, but what we are seeing is a progressive prolongation of the PR interval. The PR interval is variable. The PR interval is variable. There is progressive prolongation of the PR interval, and there is a progressive prolongation of the PR interval. So here you can see that the P has been generated, the PR interval is so prolonged, and the QRS complex that was supposed to come is not there. So there is a block, there is a sudden drop of the beat. So that is your type 1 second degree AV block. PR interval is variable and there is a progressive prolongation of the PR interval and a sudden missed beat. Okay. Now let us look at the type 2 second degree AV block. So we are dealing with second degree AV blocks and we are dealing with type 2 second degree AV block. So in your type 2 second degree AV block, what happens here? This is your PR, this is your PR, this is your PR. So the PR interval is fixed. Okay. What happens here? Suddenly there is a drop. So this is a dropped beat. But what happens? The PR interval is fixed. It was not a progressive prolongation or a variable PR interval as seen in type 1. So this is your type 2 Mobitz second degree AV block. Okay. So second degree heart blocks itself are given the name Mobitz second degree heart blocks. These are classified as type 1 and type 2. Type 1 is called as your Wenckebach. Okay. Now let us look at advanced second degree block. What is the meaning of advanced second degree heart block? Now you can see that this is a normal complex, then you have a P wave and a missed beat, normal complex, P wave and a missed beat. So these missed beats after the P wave are coming at regular intervals or in other words, they are coming more in continuity. So, more, two or more, if there are two or more such missed blocks, we call it an advanced second degree heart block. Okay. So, we have finished second degree heart block with this. Now, let us look at complete AV block. In a complete AV block, what happens? The P wave is coming at its own will and the QRS complex is coming at its own will. So, the P wave and QRS complexes are not related to each other. So, this is the meaning of a complete AV block or a complete AV dissociation, atrioventricular dissociation. Okay. So, now we have understood till here what. So, now we have understood till here what is your first degree AV block, second degree AV block and a complete heart block. Alright. So, let us look at the indications for a pacemaker. In other words, how do you manage these bradyarrhythmias at the SC node and AV node? So, third degree heart block and type 2 second degree AV block. Third degree AV block and your type 2 second degree AV block is a definitive indication for a pacemaker. So, a third degree AV block and a type 2 second degree AV block is a definite indication for a pacemaker. In type 1 second degree or first degree, if the patient is symptomatic, if he is having a lot of hypotension or if he is having evidence of neuromuscular disease, then you will have to do a pacemaker. Okay. So, what is the role of this pacemaker? So, wherever there is a block, it goes and stimulates it and makes sure that all the chambers are activated. It makes sure that all the chambers are activated and the sinus rhythm is restored. Okay. So, that is about the management of your AV blocks. Fine. So, with this we will look at the overall approach to bradycardia and thereafter we will look at some of the ECGs. Okay. So, now what is bradycardia? The heart rate is less than 60 beats per minute. So, now P wave is present. If P wave is present and each P wave is followed by a QRS complex, it is a sinus bradycardia. It is a sinus bradycardia. Now, each P wave is present but the PR interval is prolonged, then this is your first degree AV block. This is your first degree AV block. Then you have PR interval is variable, right? It is variable, then it is your second degree but type 1, which is your Venki back. If PR interval is fixed and there is a sudden drop, then this is your type. If the P and QRS complexes do not have any relation, then this is your complete AV dissociation. This is your complete AV dissociation. Okay. So, that is about your approach to bradycardia. Now, let us look at the ECGs. Fine, let us look at the ECGs. Now, can you see here, look at the PR interval. The PR interval is definitely more than 0.2 seconds. So, this is your first degree AV block. This is your first degree AV block. Now, see here, the PR interval is getting progressively prolonged and there is a sudden drop. So, the PR interval is getting progressively prolonged and there is a sudden drop. This is your Mobitz type 1 or Venki back phenomenon, which is a type of a second degree AV block. Mobitz type 1 second degree AV block. In your Mobitz type 2, the PR interval is fixed and suddenly you have a missed beat. The PR interval is fixed and suddenly you have a missed beat. Now, a second degree AV block, which is your 2:1, means an advanced second degree, So, normal, missed, normal, missed, normal. This is your advanced second degree AV block. Now, let us look at the third degree AV block with a junctional escape. That means what? The P wave is here. The normal QRS is missing. Suddenly the ventricle is having a capture or a junction. The junction is picking up and having its own complexes. And then again you have a P wave missed junctional escape. So, this is what we call as a junctional escape rhythm or an advanced AV block or a third degree heart block or a complete AV dissociation. Okay. So, I hope you have understood the approach to bradycardia based on these ECGs. Now, let us go to the next level at which the block can happen. So, we have finished the SA node, we have finished the AV node. Now, let us go to the next stage. Fine. So, we have finished the SA node, we have finished the AV node. Now, let us go to the next, which is your bundle branch block. So, after the AV node, we have the His bundle, which breaks down into the left bundle as well as the right bundle. So, if there is block at any stage, you get your bundle branch blocks. So, let us look at your right bundle branch block. Okay, so this is the AV node and this is your right bundle and the block is here. Now, what are the ECG changes that you can see in right bundle branch block? Again, we will take an example of this in lead V1 and lead V6. Now, V1 is facing the septum, V6 basically records the electrical activity from the lateral portion, right. So, in V1, what happens? There is a right bundle branch block, correct. So, can you see in this diagram that we have already learnt in our approach to chamber enlargement and hypertrophies and in our basic ECG lectures that the activation is first begins from the septum. Activation of the ventricle begins first from the septum and moves from the endocardium to the epicardium, right. So, it moves from the endocardium to the epicardium. Now, in a right bundle branch block, where is the block, right? So, the septal activation itself is delayed. The septal activation itself is delayed. Okay. So, in lead V6, what happens in lead V6? The impulse comes like this, but there is a block here because of the right bundle branch block. So, this will move here. Okay. So, it comes here, there is a block, so it changes its direction and goes towards V6. So, it will record a first positive wave. Followed by that, it undergoes muscle to muscle activation. And then goes up and depolarizes the septum. Because of the right bundle branch block, it undergoes muscle to muscle activation and then depolarizes the septum. Okay. So, that is the reason why in lead V6 you will get a positive complex followed by a negative complex as the electrical activity moves away. Now, how is this seen in V1? In V1, what happens is that you have an initial positive wave as there is some amount of positive deflection as the electrical activity comes before it encounters the block. Now, once it encounters the block, what does it do? It starts moving away. So, it starts moving away from V1. So, you have a first positive and then you have a negative wave. Then again it comes back in this way and then activates the septum. So, you will record a third positive wave. This is what we call as your RSR prime pattern, which you see in your right bundle branch block. Okay. So, I hope you have understood what is the mechanism of the RSR prime pattern in your right bundle branch block. Fine. So, let us look at the ECG here. So, can you see in V1 you find a positive, negative and then a positive. This is called your rabbit ear or your RSR prime pattern. But in V6 you have a positive and deep S waves. The S waves become more deep. So, this is your RSR prime pattern in V1 which you see in right bundle branch block. Apart from that, what are the other things that you will see? You will find a wide QRS complex. Why will there be a wide QRS complex? Because there is increased ventricular activation time. Because of the block. Okay, and there is increased muscle to muscle contraction. So, there will be a wide QRS complex. The depolarization of the ventricle is delayed. Okay, so you have an RS prime pattern in V1 and a QRS pattern in V6. So, that is about your right bundle branch block. Okay, now let us move to left bundle branch block. In a left bundle branch block, can you see from this diagram that the block is here. So, first you will have septal activation. The septal activation proceeds normally. So, in lead V1 you will have a first positive wave. Okay. Then what happens is that it has to go and activate the ventricle this way because the left bundle is not activated. So, the second complex will be away from V1 and you have a D S wave in V1. Whereas in V6, because of the left bundle, what happens is that there is a septal activation followed by direct ventricular activation, which results in two waves which is looking like the M pattern in V6 or the RR prime wave in V6. Okay. So, if you see the ECG here, can you see that there are deep S waves and you find your RR prime waves in your V6 or positive waves in your V6. Okay. So, you will have a wide QRS complex again. In V6 you will have RR prime waves and in V1 you will have deep S waves, Okay. There can be STT changes in the opposite direction. As well. So, these are the salient features about left bundle branch block. Now, what is the importance of the left bundle branch block? So, a very important criteria that you should be knowing is your Garbosas criteria. What is the significance of this Garbosas criteria? Because if there is a new onset left bundle branch block, or if you have to diagnose a myocardial infarction in the presence of a left bundle branch block, in the presence of a LBBB. We know that in LBBB itself you can have STT changes. So, how do you identify an MI in an LBBB? That is when you have to use this Garbosas criteria. So, a new onset LBBB with chest pain, you always have to rule out an MI. Okay. So, in normal LBBB, you see that there is some amount of discordance. You see that the QRS complex is wide and the STT changes are in the opposite direction. So, the Garbosas criteria basically has these three features. So, in a patient with LBBB, you have found an LBBB on the ECG, you have concordant ST segment elevation. That means what? The QRS complex is positive, ST segment elevation is also positive. A concordant ST segment elevation more than 1 mm, then it is given a score of 5, or this means that there is a chance of MI. Then we have a concordant ST segment depression. So, concordant ST segment depression means the QRS is also negative and the ST segment is also negative, especially in the leads V1 to V3. So, if this is also more than 1 mm, then this is considered to be positive and a score of 3 is given. So, concordant ST segment elevation more than 1 mm, concordant ST segment depression more than 1 mm in V1 to V3. If there is a discordant ST segment elevation, this can be seen in LBBB also, but it is more than 5 mm, right? If it is more than 5 mm, it is excessively discordant, then it is given a score of 2. So, this is how you use Garbosas criteria in the diagnosis of MI in the presence of a left bundle branch block. Okay. So, with this, we come to the end of our discussion on bradyarrhythmias. We have seen how do we approach bradycardias. We have seen about the SA nodal related bradycardias, AV nodal blocks. We have looked into the right and the left bundle branch block, and we have also looked at the indications for pacemakers. Okay. So, in the next session, we will be discussing about tachyarrhythmias. Thank you.